Assalamu alaikum. This is a presentation for medical students by Dr. Mumtaz Ahmad Umar, and today's topic is otitis externa. So this is part 2 of our previous presentation on otitis externa. In this presentation we will be covering the fungal otitis externa, viral otitis externa, and the reactive forms which are eczematous, seborrheic, and neurodermatitis. Now the fungal, the most common or the main single fungal otitis externa is known as otomycosis. It is the fungal otitis externa with fungal infection of the external auditory canal. It is mostly seen in hot and humid climates, and then in those people who use the topical antibiotics for long term with or without steroids, and definitely in people who have weak immunity. Causative agents, mainly the infective organism is Aspergillus, which affects 80 to 90%, and this Aspergillus also, Aspergillus niger is the most common one. It appears as grayish black, fluffy, wet paper, and sometimes dirty debris in the ear canal, and often mistaken for excessive earwax. But the difference will be it will be wet, and when you remove, it will be clear that it is not wax, it is fungal infection. Then Aspergillus fumigatus, it is of greenish blue color and cotton wool like, fluffy like. Candida in 10 to 20% people, the infective organism is Candida, which is white creamy debris or cheese-like discharge. In symptom, the main symptom of fungal otitis externa is itching. There will be intense itching, discomfort and irritation in the ear. Earache, which I have seen is usually present, but again depend upon the type and condition and state. If the fungal infection is severe, then pain is there, and there is also chance of secondary bacterial invasion as well. There will be watery discharge with a musty odor and ear blockage, oral heaviness and blockage, hearing loss, which is of conductive type. So these are all causes of conductive deafness as well. Otoscopic examination show blackish, gray, green, yellow or white discharge, hyphae, debris, anything can be there. Uh, One feature of fungus is that the debris is usually very sticky and thick and not easily come out on suction and cleaning, and tends to recur after cleaning. So regular cleaning is very important for medication to work properly. Occasionally, the debris is seen with visible fungal hyphae. Aspergillus niger, it appears as black-headed filamentous growth, while fumigatus appear as pale blue or green, and candida appear as white creamy. So these are important points as they can come in MCQ. Meatal skin appears sodden, red, edematous. So if we look at this picture, these are fungal hyphae, debris around. This is white creamy deposit. This is blackish with white fluffy mass here. So this all filled and covering the eardrum. Here there is hole there. So these are the pictures of fungal otitis externa. Again, these patients usually come with ear blockage, heaviness, and itching. So if you see all there, these are fungal hyphae, broadened view, they are there with debris. So treatment, as I already mentioned, oral toilet is the main treatment option with suction cleaning, which is the mainstay of treatment, and regular. After every 1, 2 days, 3 days for initial 1 week, we have to do dry mopping or warm saline irrigation, sterile under aseptic conditions. Then topical antifungal medication in the form of drops or creams. After cleaning, antifungal agents are applied to the ear canal to kill the remaining fungus. Clotrimazole solution, it is available. Nystatin solution, they are available, and clotrimazole cream or ketoconazole cream, they can be applied. Acidifying agents, because as the inside of ear it becomes alkaline, it will lead to fungus as well as bacterial invasion. So acidifying agents help restore the ear's natural acidic environment and inhibit fungal growth. So acetic acid, which is white vinegar, aluminum acetate or 2% salicylic acid, the drops Foreign countries, they are available in the form of drops, but here the drops are not properly available. So if one has to apply, so white vinegar 1 drop twice a day can be used, if the doctor prescribed. Analgesic, again, the intensity of pain is not that much severe as in bacterial otitis externa. So brufen, ibuprofen or flurbiprofen, according to the intensity of pain, can be prescribed. But important thing is to keep the ear dry. Avoid swimming. Cotton should be placed while bathing, but it should be soaked with Vaseline or use earplugs or shower caps. Now the viral, there are two types. First is the otitis externa hemorrhagica. It is painful infection of the external auditory canal, usually viral in origin and commonly seen in influenza epidemics. It is characterized by formation of hemorrhagic or blood-filled blisters. The bulla, they appear in the skin of the external auditory canal or deep meatus and often extending to the tympanic membrane. Patient will present with earache, blood-stained discharge or blood discharge from the ear. There will be ear blockage and hearing loss. Otoscopy will show bluish or reddish blood-filled vesicles or blisters in the ear canal or on the eardrum. Treatment is, because it is of viral origin, so antibiotics can be prescribed depending upon the condition and to prevent the secondary bacterial infection. Analgesics, tablet Froben, which is flurbiprofen, 100 mg BD for 5 days, Augmentin 1 gram BD for 7 days, and topical antibiotics with or without steroids can be prescribed. So this is the blood-filled blister. This is TM. Here the blood is on the tympanic membrane. This is the bulla. Uh, there is another condition which is bullous meningitis, which is another condition similar to this with viral origin, but in bullous meningitis, this blood-filled bulla are only present on the tympanic membrane, whereas in otitis externa hemorrhagica, the bulla can be present anywhere in the external auditory canal. The second is the herpes zoster oticus, which is, and again, due to a viral infection and caused by varicella zoster. There will be reactivation of this chickenpox virus. This chickenpox virus or the varicella zoster virus, it is stay in the geniculate ganglion and become reactivated, uh, leading to inflammation of the facial nerve, and it may often spread to vestibulocochlear nerve because both are closely related in the internal acoustic canal. This is the same virus that caused chickenpox, and when chickenpox is there, it is the primary infection, whereas shingles or this herpes zoster oticus, it is its reactivation occur after its reactivation. Pathophysiology: the varicella zoster virus reactivates in the geniculate ganglion and spread along the facial nerve and sometimes along the vestibulocochlear nerve, leads to inflammation, nerve edema, nerve damage, and resulting in facial palsy along with vesicles along the distribution of the facial nerve with ear pain. So there will be classical triad of spherotalgia. In shingles, shingles pain is also very severe. Malignant otitis externa, excruciating pain. Shingles, excruciating pain. Rest, severe pain, but not excruciating in comparison to these two. Then vesicular rash, these fluid-filled blisters, they present in distribution of facial nerve along the pinna, external auditory canal, sometimes on the tympanic membrane, and sometimes on the tongue and hard palate. There will be ipsilateral facial paralysis. However, in 30% of cases, there will be no rash. Treatment: prompt initiation of treatment should be done. Antivirals should be started. Steroids have to, this is the mainstay of treatment to relieve the edema, and eye care due to facial palsy. This has to be carried out. The medical treatment: antivirals, either acyclovir or valacyclovir, it has to be given for 7 to 10 days. Prednisolone to reduce the inflammation. However, one has to be careful when prescribing prednisolone about the sugar status, and you may have to consult the medical specialist to control the sugar and adjust the dose accordingly. Pain control: NSAID, and for neuropathic pain sometimes gabapentin has to be added. For eye care, because there will be incomplete closure of eye, so artificial tears has to be prescribed and lubricating agents to prevent the keratopathies or corneal injury. and in the night eye patch has to be applied. Vesicles, as I already mentioned, appear in the branches of the facial nerve, mostly in the pinna, concha, lobule, tragus, external auditory canal, and tympanic membrane. So, this is the patient. There is discharge, vesicles is appearing, and facial paralysis of the left side. Uh, this eye is closing, this is incomplete. There is drooping of the angle of jaw, but here it is maintained. Nasolabial fold is absent. So mostly this type of picture is given to you in your OSCE or Viva exam, and many times student they fail to tell the site, and the normal side they will said that the facial is bell palsy or facial palsy of right side, whereas it was of left side. So be careful while examining or judging. Now last group is the reactive group, which is divided into three types: eczematous, seborrheic, and neurodermatitis. Eczematous externa is a chronic inflammatory condition affecting the skin of external artery canal. It is a hypersensitivity, type 4 hypersensitivity reaction to or the systemic atopic response. The common triggers, it may be due to contact allergy to nickel, earrings, neomycin, this is the medication, hair dyes, hearing aid materials, anything which come in contact to the ear skin, or atopic history, those with have strong association of asthma, allergies, or generalized eczema. Common causes and triggers, dermatological conditions frequently associated with atopic dermatitis, psoriasis or seborrheic dermatitis. Then this again the repetition, contact allergies to the irritants. Irritants sometimes this is not mentioned. Excessive moisture, those who swim a lot, or those who scratch a lot with cotton buds, leading to local trauma and which can exacerbate the condition. Clinical features, there will be intense irritation, persistent itching. Ear canal may appear red and moist and erythematous because when you scratch too much, the superficial layer of the skin of the external auditory canal, it is peeled off, and the underlying skin which is there, it is red, congested, and moist. There will be formation of vesicles with oozing and crusting in the ear canal, along with fissuring, desquamation, and flaking when the condition persists. Treatment, the first and foremost is avoidance. Identify and remove the allergen or the irritating factor. Apply steroids in the form of drops or cream, and any oil-based drops, emollients. Dry ear precaution, same. Keep the ear dry. In the previous slide, you can see in automycosis I have written, uh, put cotton soaked in Vaseline while taking bath, or use earplugs, and avoid irritants. Switch to fragrance-free soaps and avoid inserting any object into the ear canal. So you see this from the external canal, it has involved the pinna and in the scalp as well. So this is the mild form, this is more severe form. So these tubes when apply, it should be in the external canal and outside on the pinna as well. In seborrheic otitis externa, it is again a non-infectious inflammatory form of chronic otitis externa and a manifestation of seborrheic dermatitis. It is mainly seen or linked to the oily skin and associated with dermatitis, seborrheic dermatitis of the scalp. It occurs because of an overreaction of the skin's immune system to an overgrowth to a yeast called malassezia. Here, this is a yeast which lives on the skin, and it is an overreaction of skin immune system. So these are different pictures again, uh, showing extension into the pinna and in the external auditory canal. There will be intense itching, and there is itch scratch cycle. What happen? You scratch the ear with a cotton swab, it will relieve but exacerbate the condition, and there will be a cycle. Later on, the itching will return. There will be scaly and flaky skin affecting the pinna and canal along with dandruff on the scalp. Otoscopy show greasy, yellowish scales over an erythematous base, and it often extends to the concha external canal, lobule, and the post-auricular crease. Treatment focuses on the treatment of ear ailment, controlling the skin condition and the scalp condition. So topical steroids, drops or creams, antifungal agents, because malassezia, it's a fungus or yeast, so antifungal drops will be advised. Topical creams containing, if this not effect, then you can use the cream containing salicylic acid and sulfur. It is also effective. Acidifying drops like acetic acid, they will also be effective, and dry ear precautions, which I have discussed previously, should be maintained. The last is the neurodermatitis. It is a psychogenic or habit driven condition where intense persistent scratching leads to a scratch itch cycle. Scratch, it gets better, but it comes back again and again scratch, and it can lead to inflammation and edema and secondary bacterial infection as well, caused by a compulsive scratching due to this is a psychological condition. Excuse me, this is a psychological condition. Actually, there is nothing wrong, but because of persistent habit of using the cotton bud or any other object to scratch, patient feels that their ear has problem. They will not get better unless they scratch the ear. Patient's main complaint is itching, and it can followed by bacterial otitis externa. Treatment counseling is very important. Break the habit of inserting objects, and psychotherapy. If it is not possible, then put ear pack and bandage to the ear to prevent compulsive scratching. And topical steroids like in seborrheic otitis externa prescribe the same medications. So these are the picture showing for neurodermatitis. So thank you.